learn through the experience I'm teaching you. So first of all, once you finish the course, once you've cleared your theory exam, forget that whatever you are reading in the textbook is correct. You start questioning the things what you learned in the textbook, because a lot of textbooks are written for the foreign, the Europeans and American skin. Our skin type is completely different, and our findings are completely different. Try to learn by your own experience, and try to understand from the people from India, because we deal with a lot of Indian clients. So obviously, we know the common issues. So we'll start the lecture today. Today is the basics of liposuction. I'm not going to deal with the advanced liposuctions like a sculpting work and all those things. I'll just touch upon those things. But once we finish all the basics in every topic, we'll go to the advanced versions in a second set of lectures. So the first thing, whatever the client come to you, I'm going to see, I'm not a theory person, okay? Don't ask me what is super wet technique, what is wet technique and all. I'll give you the practical things, and whatever you ask, if I know, I'll tell you, okay? So because I have not taken much classes for the postgraduate, so my theory knowledge will be very less, okay? So the first question what people ask as soon as they come for the consultation, doctor, I'm going for liposuction of the tummy. Okay, once I do the liposuction of the tummy, again I put on weight in the particular area. It is a very common question every client of yours asks. Okay, so first we have to understand the concept of the fat cells. Okay, see, if you're having 1,000 fat cells in the body, it's going to be 1,000 fat cells till we die. When we do liposuction, we manually remove the fat cells. Once we remove the fat cells, that area, see, obviously you can't remove 100% of the fat cells in the particular area. See, probably we remove 70 to 80% of the fat cells in that area. So we are reducing the number of fat cells. After the liposuction, if they gain weight, the fat cells, the existing remaining fat cells might become bigger. You got the point? So obviously you have to make the patient understand, unless otherwise they maintain their weight, they might put on weight in that area, but not like earlier. Other major problem, why you have to understand this concept is because after the liposuction, if they gain weight, other areas becomes abnormally big, because till before liposuction, all the fat will accumulate in the tummy. Example, the tummy liposuction we did, because tummy is a resistant area for him, so it came to you. So all the fat cells becoming bigger in the tummy area. We are reducing the number of cells in the tummy. What happens? The fat has to go and store somewhere, so it goes to the other areas. This concept you have to understand to make the patient understand this concept. One more thing I wanted to understand is, this is a little older concept. There is no new fat cell formation concept, but there is a lot of precursor cells in the body, progenitor cells in the body. See, when you give the particular stimuli, say example, you keep eating and you're not exercising, what happens? The stimuli goes towards the fat lineage. So the fat, there is a possibility that new fat cell formation also, if they gain a lot of weight. Say example, usually what I tell my patient is, if you gain more than 15% of your body weight, there is a possibility that you might get the fat in the same area. So this one you have to understand. So I think I'm clear in this point, because this is the first thing what any patient asks you. So this is a little common anatomy of the fat. See, a lot of textbooks says it's a superficial layer, intermediate layer, deeper layer. Usually most of the works are in the intermediate and deeper layers, and the superficial fat, usually it is dense and very adherent with the skin. When you do the superficial liposuction, yes, we do superficial liposuction in sculpting work, but if you're not careful, what you end up in getting the skin irregularities as well as the skin necrosis, skin death, and pigmentation. These are all the complications happens if you are doing a lot of superficial liposuction. So usually this is the diagram of how superficial fat and intermediate fat and deep fat looks. Thanks to Karan for the images. And now if you see each area, the distribution of the fat is different. For example, abdomen, superficial fats are more and deep is little less. And if you take the paralumbar region, deep fat is more and the superficial fat is less. And gluteal region, superficial fat and deep fat almost equally located, gluteus and thigh region. Leg and all, if you see, there is no deep fat at all. So this is just an arbitrary thing. See, in two areas it's important because paralumbar region, if you go with the skin fold thickness, see, usually what we do after the liposuction, we see the skin thickness. Okay, the skin almost fat has gone kind of, but paralumbar region, you have to go a little deeper to remove the deep fat because a lot of deep fat cells are there in the paralumbar region. So these milder differences only, but you have to understand this concept to when you're doing a liposuction. You have to have mental picture. Okay, here deep layer is more, the superficial layer is more, like that. But practically, it won't be much useful. So the decision making. Somebody is drawing or something. Okay, sorry. Decision make. See, in this heading only we are going to see we are going to discuss the upcoming the whole topic. So we are going to take how we are going to take the decision, and preoperatively what are the things you need to take care of, and intraoperatively what are the things you need to take care, and what you see immediate post-op, and what are the complications seen in the late post-operative period. In this heading, we are going to see the whole lecture today. Decision making. So you tends to get three kinds of patient to you. Okay, the patient is almost ideal weight, maybe the few kgs extra, but some areas are whatever exercise they do, whatever diet they follow, they never respond to diet or exercise. So these are all the ideal patient for liposuction. It's called resistant fat, and this is the patient usually needs a body sculpting work. This is only the interesting patients to operate, and not the overweight patients or morbidly obese patients. The other category what you get is the overweight patients and morbidly obese patients. I'll show you a few examples now. So this is a almost ideal weight. She's an actress and she wants to have the good curves and the two packs and the like prominent iliac crest. And their expectations, as when you're operating on the actress or a models or anywhere in the show business, their expectations are extremely high. So I'm not saying that in the initial days you should not take, but make sure that you give them the clear picture what you can provide. Because initial days, their expectations are very high. We want to convince the patient. We never ever give a over promise. Never ever do the over promise, because end of the surgery they'll sit on your head and they'll hit your brain because their expectations are different, and we promise so much to them. So give less promise and do more. Give more results. And in this case, we did a sculpting work. I'll show you this video. I recorded this liposuction video. End of the whole lecture, I'll show you the video. So this is what we got after surgery: one midline groove and the curves and the two packs. So this is what we got during we created this one. This is little. So if you see a little close up, you can see in the lumbar region somebody's fighting. I don't know, some chalkboard things are coming. Okay. So the curves, if you see that the left the hip curves, you can see little dark hue. This is a very commonest thing what you see if you do a very superficial liposuction. You end up in the pigmentary issue. Usually the pigmentary issue settles in 6 months time. Sometimes you need to give a hydroquinone and other things to correct it. So this one you have to understand. This also the resistant fat. Usually people come with the resistant fat like this, almost ideal weight. The outer thigh is a bulgy thing. It's very commonly used in Indian patients. So this is how you get the results. So this one kind of a patient, these are all the ideal patients. And like these are all the ideal patients to operate in the initial days, because you can even use a syringe liposuction to do a small areas like this. You can do it under local anesthesia. Even if they're not happy, you can bring them back and do a milder touch-up liposuction again. So this kind of you take initial days, try to take a smaller liposuctions and you do the liposuction for them. It's easy for you. If you take a bigger case in the initial stage itself, you feel very difficult. Next comes the overweight category. Okay, overweight. there will be, usually 15 to 20 kgs overweight. Usually they come before marriage. Sir, I'm getting married, do something. This guy also, his fiancée pushed him to me to make sure that he's losing weight as well as getting the good shape. Yes, obviously the gynecomastia you need to operate. Along with the, since he asked for the liposuction, we did a liposuction of the tummy, love handle, and the lower back and the inner thigh. Okay, this is not only because of the liposuction, we lost 10 to 15 kgs weight. Okay, other common question patient asks, if I do a liposuction, will I lose weight? First answer you have to give him is no. Only contours the body, though the weight loss happens by, if I remove 10 liters of fat, probably 2-3 kgs you lose, that also will be visible only after the swelling and everything settles after 1.5 to 2 months. Till that time you feel your weight will be more because of the swelling and other things. You weigh more than the what is your previous weight. So you have to inform that clearly. So even this case, we motivated him before marriage and he lost a lot of weight also. One important finding I want you guys to notice in the pictures, see the loose skin before surgery, see the loose skin after surgery and the weight loss. In his case, because of the liposuction, skin tightening is better. It is one more indication why you select these kind of cases. Because if you make him lose weight without doing a liposuction on their own, what happens? The loose skin will be more. He'll end up in going for a tummy tuck or a breast lift procedures or a skin excision procedure, which leaves a big scar. In Indian scenario, these kind of a patient, if you do liposuction, then do a weight loss, the skin tightening is better. How skin get tightened? See, this kind of a liposuction cannulas goes under the skin multiple times in multiple levels. What happens? Every time when it goes and comes out, it produces tunnels. The healing phase, these tunnels, like collapse and fibros and bring the skin back, and make sure that it goes and attach with the skin, muscle underneath. Okay, that's the reason skin tightening happen in this patient also. Other patient, same story. We did a liposuction of the arm, upper back, lower back, thighs, buttock, and tummy also. So if you see, I'll come to the marking a little later. So this is after surgery results. If you see the results, see that she's ideal for a tummy tuck kind of. It's a pre-pregnancy, it's a before marriage. Obviously, we don't want to do a tummy tuck. So even without tummy tuck, if you see, the skin tightening is much better in all the areas. The same story here also. She lost weight also along with the liposuction. She lost maybe 7-8 kg. She lost along with the liposuction. So that then only you get this kind of a results. So when you select these kind of a patients, if they are highly motivated and they're understanding the pros and cons of the liposuction very well, and they're ready for the dieting and exercising post liposuction, only you have to select these patients. If they come and say, doctor, I'm very busy, I don't have time to do diet and exercise, never ever take them for surgery. They have to clearly understand the pros and cons. So next comes the obese patients. See, these patients, my first advice is never ever take this kind of a patient. This is very, very long time back. Probably I can say when I started my practice, the first year of my practice. So I did a liposuction of the tummy, chest, and the little kind of arm lift. I don't know what I did. Arm lift, even I'll show the post-surgery results. Arm lift, I don't know what I did. Still it is sagging only. So I did a liposuction of the chest, tummy. Sometimes we can take them for surgery. Even now, I operate this kind of a patient sometimes. The same story. They're highly motivated. They don't want to go to bariatric surgery. They want to lose weight by diet and exercise. And there should not be any complication like diabetes, hypertension, and those kind of a complications should not be there. This is my indication. Okay, it might vary from person to person. And they're young, less than 30 years, no comorbid factors. They're willing to do any kind of a surgeries. I do chest, tummy alone. I don't put them on the back. I don't turn them, like prone position and all. only supine position, do whatever possible and come out. This is called encouraging liposuction. They don't know where to start, so obviously they come up with a they come for liposuction. So, but this guy also never followed anything post surgery. He said he was going to follow, but he never followed. But surprisingly, what happened? Sorry, 1 minute. Yeah. I think I need to go back. Yeah. Okay. Surprisingly, one thing happened. Sorry, something. Okay. This is how he was looking after the now. Okay, not because of my liposuction. After like 2 years back, he got highly motivated and he did a lot of dieting exercise. Now he is into marathon running and other stuff. Okay, but you have to motivate them so much, then only you can take these kind of a patient for surgery. Okay, pre-operatively, what are the things you need to see? You have to thoroughly evaluate them, and then the instructions and marking. I'll come with how will you evaluate the patient. The psychological evaluation is very important in any cosmetic surgical patient, because in our practice, any cosmetic surgeon's practice, almost 15 to 20% patients are body dysmorphic disorder patients. It's very difficult to find out in the earlier stage, but later stage, if you find out also, they don't leave you. They want you to keep operating on them, and you can't avoid them. It's a big headache for you. So make sure that you find out the body dysmorphic disorder patients. Usually they'll have a history of the bad childhood history, like sad childhood, some close relatives died unnaturally, and these are all the very common thing you pick up from them. And usually they say that it will be a milder problem, but they keep telling this is everybody commenting about it. Everybody, if I walk in the street, everybody noticing that only. They're not seeing my face at all. If there somebody is coming and telling this kind of history, your red light has to brighten up, because these patients you should not even touch. And even other histories, like any family history of mental disorder, also very important. Second thing, lifestyle. After surgery, whether they can do good kind of a regular maintenance of the weight by doing dieting and exercise. If their work schedule not allowing them to do anything, obviously you should not operate on them. And why I put education here is, uneducated people, sometimes it's very difficult for you to make them understand the pros and cons of the procedure, and you can't make them do post surgery the maintenance things. And one more thing is, uneducated people, when they're coming, they always feel that okay, they're paying this much amount of money, everything is over. Post surgery, they did not do anything. That kind of attitude usually they have that uneducated crowd. They usually have. Make sure that even if you take them, they completely understand the pros and cons. Otherwise, it's very difficult for you. Usually in our centers, we do few routine pre-operative instructions. All our patients, any cosmetic surgery procedures, the night prior to the surgery, morning before they come, they take a betadine scrub bath and come. And then come any comorbid factors. See, if they have any comorbid factors like a thyroid, it's a very common, like any other surgeries, like thyroid medication has to be taken in the morning of surgery. Diabetic medicine has to be skipped in the morning, and hypertensive medication has to be taken in the morning of surgery, sips of water. Blood thinners has to be avoided at least a week prior. The smoking is a very important thing in any cosmetic surgery. If you should not operate on the smoker. If you operate on the smoker, at least 3 weeks prior to the surgery, they have to stop smoking. And sometimes it's a very small procedure, at least 1 week, they have to stop smoking. Otherwise, what happens? The skin necrosis is very common. Skin pigmentations are very common, and even anesthesia-related complications are very high in the smokers. If you're planning for a long hours of surgery, obviously smoking has to be stopped at least 3 weeks prior to the surgery. This is my first case. I did my liposuction 12 years back, and I don't even understand the marking now. Even my six pack is like kind of a become conical in the upper part. I don't know why I mark that way. But our marking slowly improves. See, the marking, there is no hard and fast rules. Everybody asks, sir, explain more about the liposuction marking. There is no hard and fast rules. We make rounds. If you see that the lower tummy, I made the round. What does it mean? There is a fat deposit and bulge is there. The visible bulge is there. And this is a case for the six-pack creation, high definition liposuction. So I made the lines by making him crunch, and I felt the lines and marked the lines. If you see that, like the pararectal area, I made like a hatch marks kind of. If you see any kind of a six packs or any kind of a sculpted body, there is a lot of shadows you have to start noticing it. In liposuction, the shadows are very important. Where the shadows are, you need to do a lot of liposuction, and you have to do superficial and deep, and you have to make it completely paper thin. Okay, so and same way in female liposuction and all, normally from the navel, if you draw a line 45-degree angle, that is a curve, the maximum curve what normally you see. So you have to mark in the front as well as from the back. So that area you have to remove a lot, so that curve will become more visible. So same way, if you are doing in any like thigh or any place, if you make a big circle, it is a area where that maximum fat located. If you go and draw inside a little bigger, smaller size circle, that means that is a maximum projected area. In the sides, I need to feather it out. Not that completely. That you have to, the basic idea, why do you do marking? When they stand, where are the projected areas and where are the fat areas? And one more thing is, where are the grooves? You need to mark the groove. Sometimes in the bra roll and all, there is a groove forms here. When they lie down, the groove will disappear. You need to know where I need to remove a lot. I need to dissect the groove so much so that the groove will disappear. This kind of a mental idea. If you see the thighs, I wrote no in the middle of the thigh. I draw two lines. I wrote NO, no. Why I made that mark? If any limb surgery, liposuction, if you do circumferential liposuction, what happens is the distal edema will be more. So you have to leave a strip of area where liposuction, you should not do a liposuction. Then only that distal edema will be less. Even the arms, any extremities, when you're doing a liposuction, you have to leave a strip of skin. Otherwise, the distal edema will be more. And intraoperative, the time is okay?
Yes, sir.
Not bad.
They have extended the time, sir.
Okay. The intraoperative. Intraoperatively, three things you need to know: technique, machines, and fluid management. See, we use a little modified tumescent because I've seen in few centers across in US, and I modified a little. If you see what tumescent solution, what I use is, I use for a liter of 1 liter of ringer lactate. I use ringer lactate. Some people use the normal saline. Doesn't matter. So we add 2 ampules of adrenaline and 15 ml of 2% lignocaine and 10 ml of ropivacaine. Earlier we used to use the sensacaine, but the cardiotoxicity of sensacaine we don't want to take risk, so we switched over to ropivacaine. And we add one more thing, triamcinolone we add normally because post-operatively swelling will be less. So I add 10 milligram of triamcinolone in 1 liter of ringer lactate. So post-operative swelling will be less. But you need to be careful when you're operating on a diabetic patient. You should not add triamcinolone, and adrenaline should not add more. Maybe a 1 ampule is adequate. These two will aggravate the blood sugar level in the post-surgery. So then you need a good infiltrator. The infiltration is equally important because when you nicely infiltrate that area, the fat cells has to swell up, and that vasoconstriction effect should be more adequate. Otherwise, you can't do a major area liposuction. Otherwise, you have to end up in a blood transfusion. So, good infiltrator is always important. You don't go for the expensive ones. Even 40,000-50,000, you get a very good infiltrators nowadays. See, I use the power-assisted liposuction, but I don't have experience in laser or a laser. But power-assisted give equally good results. And even my chief, Dr. Ari Aramugam, he uses syringe liposuction till the end of his practice, and he get a equally good result. So, end of the day, machine matters when you are doing a major volumes. But even smaller volumes, don't invest in the machines. Even the syringe liposuction is more than adequate if you do it in proper way. So this is the machine what I use. This is a power assisted liposuction called micro air. we use this machine, and I'll show you the video. At least you'll have idea how we do the surgery. This video I'll show you later. Dr. TNS sir, can you take over from here? For the fluid management, Dr. TNS, Dr. Thirinjana Samundam is our anesthetist. Because of him only, we are very carefree post-surgery because he manages everything. So I think he's a better person to explain you about the fluid management. Yes, sir.
Yeah, good evening for your good words. And then straight away, we will jump into this topic. It is a vast one, but then I know that it's a small part in your presentation. Am I audible?
Yes, sir, you're audible, sir.
Okay, Karan. So it is not something of a magic, but then you got to get it right. It's so very, very important and vital. Coming to the outcome, fluid management plays a pivotal role. And when you take body contouring, one thing everyone should have it in mind is body contouring definitely doesn't need fluids at all, actually speaking. And then what happens to your tumescent when it has been injected into your subcutaneous and then superficial layers underneath the skin? Approximately one third of the fluid gets absorbed into the interstitium. So that is what happens. So this is what happens when you inject, but then no, it is a question of time. And there are two variations, like some people do the liposuction immediately, some people tend to wait. So if you tend to wait, the dwelling time, if it increases, the absorption from the infiltrating layer into the interstitium will be much more. So it will be nearly like one third to nearly half of the fluid might get absorbed if your waiting time increases. So that you have to have it in mind. And as far as possible, if the aspirate doesn't cross 5 liters, which is the maximum limit for an office daycare liposuction, that is simple body contouring, where majority of the cases doesn't need to just cross this limit. You need not worry about fluid management at all, and you need not even give fluids. It is just a vehicle that you need to administer other drugs. That's it, because the absorbed fluid from your tumescent, that itself will take care of the maintenance needs. That is more than sufficient. You're not losing much heme, and if your aspirate is not having much blood. The problem comes when you lose blood. That is where, see, the worst complication after a liposuction is big hematomas and then hypovolemia and death. That is the commonest. And let me, before that, I will come to the fluid management, what we do regularly. See, what happens if you are infusing more fluids for that matter? So inexperienced anesthesiologists tend to give more fluids because they think they're going to aspirate so much along with the fat, and then they think that there will be more blood loss or there will be more fluid loss. There is no point administering IV fluids. I'll make it clear. See, whenever you give some crystalloid, we use crystalloids like ringer lactate or normal saline for your fluids. And then when you use IV fluids, what happens is, one second, I'll just share my screen.
I'll stop sharing my thing. Yeah.
One second. Okay, are you able to see my screen?
No, sir.
No,
No,
I
sir.
already shared. One second.
Usually ask one more thing, sir. Which
Yeah,
part of the screen? Oh, yeah.
are you able to see my screen now?
No, sir. Sir, there is a small icon, share screen, bottom. You have to just,
Yeah, I did click on that. I did click on that.
then it asks the options, sir. You just desktop screen, you do it, sir.
Yeah, desktop, 1 minute. Yes.
Yes, sir.
Yeah.
It has started.
Yeah. Are you able to see? Okay.
Yeah, yes, sir.
Uh, okay. So, am I audible now?
Yes, sir. Yes, sir.
Yeah, you
You
are.
are.
Okay. So, coming to the fluid management, so as I was telling you, when you infuse more fluids into the intravascular compartment, immediately, see, if you want to infuse some, say, 1 liter into your intravascular compartment, and then within 20 minutes, 80% or if not 70% at the minimum goes into the interstitium. What stays in the intravascular compartment is only 20 to 30%. So when you want to bring up the volume for some reason where there is no need in a liposuction, because you're not looking at hypovolemia as a cause for drop in blood pressure anyway, unless otherwise you cross your limits of 5 liters so easily. I'm not saying that you should not cross 5 liters. It is not a magical number. This way, that way, okay, 6-7 liters, and then if you are crossing that, then the fluid management becomes more complicated. So now, even then, even if you cross 7 liters of your aspirate, what happens is the fluid management depends on the blood loss, and it is very difficult to calculate blood loss in a liposuction. How are you going to calculate blood loss? See, blood, your one thing usually when we lose blood, we give 3 times more of the crystalloids. If you're losing, say, 100 ml blood, we give 300 ml of crystalloids if it is within limits. So, but then when we cross 20% and more of blood loss, like say for 5 liters, if you cross 1000 ml or more, only then we think of giving blood. Till then, we always give 3 times the amount of blood that is lost, 3 liters of fluid. But what happens, that rule doesn't apply in a liposuction. If you are giving 3 times the volume of fluid for the blood lost, then you are going to pump in a lot of intravascular fluid, which is not going to stay there, and it is going to cross into your interstitial fluid or a compartment where it is already loaded because of the movement from your tumescent. And what you are producing is ultimately an interstitial edema. And effectively, the blood pressure also will not hold because the intravascular compartment is still not full, because the fluid is constantly shifting from the intravascular compartment to the interstitium where it is already preloaded, and with the cellular edema, it is going to cause havoc in the postoperative period, wound healing, infection, and whatnot. And worst thing that you can produce is a dilutional coagulopathy. I like everyone to keep your ear sharp to listen to this. This is what you're going to produce. It's a dilutional coagulopathy that you're going to cause, because all the clotting factors, most of the clotting factors, along with fluid loss, if you're creating, what are you going to create when you do a massive liposuction? You're going to cause tissue injury everywhere, and then it is like a multi-polytrauma where there is a lot of blood loss with invisible, which is going invisible because microthrombi is forming everywhere wherever you put the tunnels, and then all over the body surface area. If you are causing microthrombi, and then it is going to consume all the coagulation factors. Already the body will be in a state of a coagulopathy, and then you dilute with a lot of intravascular fluids. What will happen? It further dilutes, and it causes ineffective coagulation that can lead on to DIC, that can set in the post-operative period. Till the patient is in your charge, the patient might be apparently normal, but when he shifted out to the post-operative period, down the line, 2 to 3 hours later, the patient can go in for further bleeding, and then hematomas everywhere, causes massive DIC and hypovolemia, and by then it will be too late for you to intervene. So you should know that whenever you cross that magic number of 4, 5, 6 at the max, 6 liters of volume that you are going to aspirate, then that should ring a bell. And you got to start intervening from then. And from there, you got to replace the blood loss only with the blood. There is no question of replacing blood with fluid. If you are crossing the limits, and if you are sure that the patient's blood loss is going beyond 20% of his blood volume, then you need to replace blood. That is very, very, very important, because if you are able to get away without any blood transfusion, well, that is good. You can still manage. If the patient is young with no comorbids, you still can take up, and he has lost approximately around 2000 ml of 1000 ml of blood loss, then still a young patient of around 30-40 years without any comorbid can still take it, but then you don't give the triple amount of crystalloids that is usually given, because 1/3 is already absorbed and then that is already there. So you need to just replace maybe 1.5 times rather than 3 times. You need to just cut short the volume replacement with the crystalloids. And still there is a limit. If you cross further, like massive liposuction, only there, then you need to give blood. There will be a definite loss of heme. And how are you going to calculate the blood loss? That is a very, very, very important step in the fluid management. So as I told you, don't drown the patient wet. That is an important criteria in liposuction. Inexperienced anesthetists just pump in volumes of fluid, and then most of the time our body can take up anything. Even if they mess up, you're going to pass out the excess fluid into the urine. But that becomes very important in case of people with comorbids and those who have a little bit of a ischemic heart disease, or even a hypertension uncontrolled, or a diabetic patient where fluid shifts are very, very worse, and they can end up in a pulmonary edema. So how are you going to calculate the blood loss, and then how are you going to monitor the fluid management? How are you going to just go about it? See, nowadays all the static parameters, what by way of heart rate, blood pressure, even if you have a CVP or a mean arterial pressure, all those things are out. That you cannot, everything will be masked, and then you will have a with a mere number you cannot calculate the volume loss or anything. And urine output can be it is just like a universal indicator of a good perfusion, but that is okay, but that won't be enough. So now the dynamic parameters which are easily available, if you have those, then you can assess the fluid responsiveness. A little bit complicated, but then it is very easy. Once you have that, you use a systolic volume variation, or a pulse pressure variation, or systolic pressure variation, or pulse volume index they call. It is easy, but then you have to have the gadget. So that can be calculated, and then fluid can be managed with that responsiveness. But don't worry, even if you don't have that also, I will tell you, it is very, very easy to calculate the blood loss. There are only if your aspirate is completely heme free, no color change, it is completely like if it is yellow in color, and then there is no heme loss, not much. And secondly, you have little color change where you can see initially when your aspirate is yellow and then slowly turning into an orangish red, and then a third which is full of heme, like no, it will be really bloody. So the blood loss can be anywhere between 3% to 10% in an aspirate. So if you are having 3%, it will be less than 3%. You need not worry at all. You need not replace. And again, if the heme is around 5%, heme loss is around 5%, then that means that the blood loss is still manageable with fluids. And if your heme loss goes beyond that, and if it is frank, bloody in color, they aspirate, then that means that you're in for trouble. And there you have to calculate the blood loss as 10% of your aspirate. So if you have 100 ml of aspirate, that means that the blood loss is usually according to the color, then you have to see 10 ml of blood loss for every 100 ml. So if your volume of aspirate is 5 liters, then 10% of 5 liters is 500 ml. Okay. So if you
Yes,
if you aspirate 10 liters, what happens? That is 1 liter. So accordingly, then you need to calculate if the blood loss is okay within the limits, or you need to replace blood. That is how it works. So if you want to replace, if you see it, if it is manageable without blood, then you want to restrict with the fluid alone. Then if it is not crossing the limits, so you should not give 3 times the fluid. You have to limit your fluid to 1.5 times. That is more than sufficient, because as I told you already, fluid shift would have happened from the intravascular compartment into the interstitium, as well as your tumescent fluid goes. And thirdly, the one important aspect is when a patient is shifted from the theater into the postoperative period, and if you are having the habit of putting the garment immediately after liposuction, some people do that. So in that case, what happens is your vasoconstrictive effect of the tumescent still stays. Hope it stays. As long as it stays for longer, it is good. It is beneficial. One, it prevents heme loss. The second thing is it actually prevents coagulopathy. Like, see, more coagulation factors are wasted. That goes into the interstitium and takes longer, but that is worthless. And if you are preventing that, and then better the coagulation factors are there in the blood, so that it can cause further thrombi and then prevent further blood loss. And if you're having decompressing effect of your garment, it is again going to just cause further movement of blood or also fluid from the intravascular compartment into the interstitium. So it is always, but we need some volume to stay in the intravascular compartment. So it is always better not to go with the tight garmenting immediately. You can just wait for a day with your dynaplast, and then slowly move on to your tight garmenting the next time. So I know the time is limited. Maybe we can discuss it further and further again. So as I told you, don't drown the patient wet. You give only limited fluids, that's more than sufficient. And whenever the blood loss is more than 20% of your blood volume, and then you don't need any more fluids, and that is, it doesn't clot or it doesn't carry oxygen either. So you need to give only blood at that time. So if you are a patient or a client doesn't want blood transfusion, you better limit your liposuction volume to probably safe limits. Safe limits varies for patients with comorbids. The safe limit varies, and for patients, and the safe limit varies surgeon to surgeon. If an experienced surgeon is doing, and if he is limiting his blood loss and the heme loss, if you can assess in the aspirate, if it is less red, then that's great. You can still move your or shift your volume of aspirate to a little bit on the higher side. But even if it is a little bloody, if you restrict your aspirate to less than 5 liters, definitely no problem. So staged or staged procedures, if you want to have to do more areas, and then that will be really helpful. I hope if there is any doubt, then I will take it up in air. Yeah.
So very nice, sir. Thank you, sir.
Thank you.
Thank you so much, sir.
Thank you, Karthik.
Then you have to stop your screen share so I can.
Oh yeah, I'm doing that. Yes.
Somewhere it will be there. Stop screen share somewhere.
So go to Zoom only. There will be an option. So should I do it? I will do it.
I did.
Okay. Thank you, sir. Yes, sir.
Thank you. Yeah.
Yes, sir. Thanks a lot, sir.
See, why I ask Tina sir to discuss about the fluid management is because most of the complications happen so even you can find out, a lot of deaths happen because of liposuction. A lot of, like big centers also, the complications happen. The problem is most of the anesthetists, even the experienced anesthetists, they don't have any clue about the liposuction details. Even we still learn, even in diabetic patients, we still learn how they behave after liposuction. So the fluid management is extremely important. The nutshell, what Dr. Tina sir told is how to calculate the blood loss, and major thing is ask your anesthetist not to overload with the crystallite, thinking that because 5 liters have removed a lot of the fluid loss is there. Never ever allow your anesthetist to overload with the fluid. These two things, even the younger anesthetists not experienced, make them understand, make them go through the whatever you learned today. And even if you are in doubt, you can ask them to call Dr. Tina sir. Tina sir will be definitely willing to help you, because immediately after you finish your course, you want to do the procedures, you stuck, and when you do the mistakes in the initial stages, your name gets spoiled and your practice will be doomed after that. So it will be careful in the initial days of your practice. So then comes I didn't tell much about the liposuction technique. No, shall I come and I'm showing the video? Because any areas when you're infiltrating, you have to infiltrate in two levels. One is the deeper fat level and the superficial fat level, if you're planning for a superficial liposuction. So two areas you have to infiltrate well. There is a sign called the fountain sign. When you inject where you made that small cut, once you take the cannula out, it has to come like a fountain. That is the end stage of your liposuction. It should be a super wet. Okay, there is, even for your theory purpose, there will be a super wet and some dry technique, something like that. So usually you have to infiltrate adequately till the fountain sign positive as much as possible. And the technique wise, I use the power assisted. Usually we go deeper and we remove the deeper fat. See, initial stages for you, it's extremely difficult to understand where are you, which plane you are in. You are deeper or you superficial. It's little difficult to understand. So initial days, try to do slowly. Don't be in a hurry to do surgeries. I do understand the theaters will charge per hour, but don't be hurry to do surgeries and end up in complications. So go first deeper plane. Usually easy to find deeper plane is if your cannula is not palpable by your fingers. See, this is your hand that the cannula goes in. You can't feel the cannula movements. You're in the deeper plane. But same time, you should not go very deeper, enter into the tummy. See, normally the tummy muscles are very strong. It's not very easy to enter unless otherwise you are not understanding. You are not stopping for the resistance. If there is a resistance, you just try to understand where you are fitting. Then you just withdraw and go above, because the deeper fat is very loose plane. So if you feel some resistance, that means you are hitting the muscles, you are going deeper. So first go and finish the deeper liposuction. Then you come to the superficial liposuction. Because when you do a superficial first, see, normally we go with the skin fold thickness. Okay, this much. Okay, initially it's 5 centimeter thickness, skin fold thickness. When you keep doing, it comes down. When you finish superficial, what happens is you have a feeling that, okay, I already finished the liposuction, skin thickness is very less. That's not the way, because still you left the deeper fat cells. So you have to go deeper liposuction first, finish it, and come to the superficial area. And when we are doing a high definition liposuction, see, we give a lot of fancy names, high definition, body sculpting, everything is a liposuction basically, understand that. So if you do a very superficial liposuction, like a subdermal liposuction, then for creating the, like the six packs and kind of a curves and other stuff, that time only it has to be very, very superficial. You have to feel the cannula in your fingers. Okay, so this is a technique basically. It's very difficult to see. Technique is very simple only. If you are doing its initial stages, do it slowly. Slowly increase the speed. Don't be in a hurry to do and keep the intestines and other things. So after surgery, we follow the Dynaplast. If the major liposuction and all, we put the Dynaplast and all over. So basically 2 reasons. One is we don't want to over compression. The same way Dynaplast just to prevent the skin edema, not to give a compression. Don't pull it like this and put it over with the over pressure. Just keep it over the liposuction area to prevent the skin edema. Okay. So once that is post surgery, the government we normally do it after 2 days. Garment means a tight fitting dress. We'll measure and we'll sometimes ready-made garments also available. Usually it gives nice pressure and contour. Most of the mistakes and most of the complication happens because of these two aesthetic complications like a skin necrosis, skin death happen because inappropriately given tight pressure by the plaster. Sometimes what happens is skin is little lax, the loose, so it will, because of the plasters, it folds. So it blood supply to the particular part will cut off because it's completely folds. Immediately after surgery, it's very detrimental. So it will be very safe. Plaster should be uniform, not much pressure. Even the pressure garment, if you're putting the pressure garment in the initial days, you have to be very careful. Make sure that it's not very tight, because in most of the countries, the abroad and the US and UK and all, they do 2 sets of garment. Initially, garment will be loose. They increase the pressure. Second set of garment, they'll give on 10th day. And even third set, they'll go after a month because they'll keep increasing the pressure. So what I'm trying to say is the pressure should not be so much in the initial periods. Understand that. Why we put the plaster, one more reason is that oozing will be there in a lot of patients in the first POD, or even some people up to 2-3 POD, post-operative days. So the dress becomes spoiled because the dresses are expensive, and it costs sometimes 10,000, 12,000. I don't want to get spoiled, so usually we use the plasters first, then we put the switch over to the garment after third day. And so these are all the very common things what I follow. Any doubts, you don't hesitate to mail me or ping me in WhatsApp and clear your queries. Don't be very formal. I'm also learning with you. Understand that. Okay. So, what are the common complications? Usually, some people they complain of excruciating burning sensation immediately after the surgery. That pain, that burning sensation won't stop by any medication unless otherwise you sedate them sometimes, or some ice pack. All those things are just to diverting them. Usually it stays there for 2-3 hours in few people, not everybody. So understand that it might be one of the initial symptoms or patient complaints of. And see, if you don't have an experienced anesthetist and you don't have a good team, you have to sit with the patient, understand what are the things can happen wrong. Lignocaine overdose, overtoxicity. Okay, so you have to understand the symptoms of lignocaine toxicity. You have to ask, unless otherwise you know about it, you won't ask the patient. Some like metallic taste, tingling sensation in the tongue, and some altered sensorium, confusion, some restlessness. You have to try to pick up those things. If it is very abnormal, usually it goes off automatically. But try to understand what happens in lignocaine overtoxicity. What is the treatment for this? Sometimes even people, I heard that they give intralipidinol. It never happened to us because of Dr. TNS. And signs of fluid overload. Okay, look for the facial edema or the basal crabs. You have to understand these kind of things. Then only you unless otherwise you don't look for it. That's a problem. So fluid oozing will be there for some time, 1 or 2 days. Even sometimes after 7 days, it opens up like a tap and a lot of blood-stained fluid will come. So advise the patient when they're going back home. When you go back home, there might be some oozing. It is very normal. It's like when you open a tap, how the water is flowing. Same way, sometimes it comes through the opening. It's very normal. Don't worry. Dry that area and make that area dry and keep it dry. That's the only thing we advise. Sometimes you ask them to use the hair dryer to dry that area and keep it dry. And same way, the fat embolism is a very common phenomena in a liposuction, even the fat transfer procedure. So even one study says that almost 70 to 80% of the liposuction patients are going through a fat embolism. But since the fat embolism is a very minor fat embolism, the signs and symptoms are not noted. It's very scary, but that's the truth. So you have to look for tachypnea, breathing difficulties, and the saturation fall. Anytime it happens, most of the time we see on table also. TNS will agree with me. So we need to, and sometimes in massive liposuction, even the smallest liposuction we have seen a fat embolism. Some lipoma removal, I did a little liposuction and then did a lipoma removal. That case went for a fat embolism. Though minor, you might happen to see the fat embolism in your practice. The massive, you don't have much control, but minor embolisms, try to manage. with identifying it early. And swelling. Some people they're allergic to plasters, allergic to even the garment materials. So we have to understand these issues. Then comes a little late post-operative issues like itching. Some people they have an intractable itching. They can't manage it anything. Usually it comes in second week of second or third week after liposuction. Usually it's a healing phase. It happens. Whatever medication you give, antihistamines or steroids or whatever, it won't stop. And usually you ask them to remove the garment. Some people are allergic to garment, and it happens in the second week. So garment removal will help them. Some people, a lot of moisturizing cream application will help, because after the liposuction, the sweating won't be good in the liposuction skin, because we do disturb the sweat glands everywhere, so that it will be dry. So if you allow the skin to be dry, two things, pigmentation happens and a lot of the itchiness will come. So make them use the moisturizing cream 2 to 3 times a day from the day one. It helps them to come out of the itching problem faster. See, if you see any the European and American skin, the white skin people, they bruise a lot. A lot of redness, a lot of ecchymosis will be initial stages, but within a week all disappears. Week to 10 days, maximum 2 weeks it disappears. But Indian skin, well, the major problem is the pigmentation. So even if you tell about this to the international speakers, they don't even aware of these things. What happens is when you're doing a subdermal liposuction and all, the superficial liposuction, we activate the melanocytes. The melanocytes produce a lot of pigmentation. What happens? That pigmentation stays there like that. It initially, I'll show you a few pictures. Maybe in the next picture, if you see the pigmentation like this, even she's an actress, and like after, usually it disappears after 6 months. It takes almost 6 months to disappear. They tell that time they have to use its makeup, and sometimes we use a hydroquinone based creams, 4% hydroquinone, sometimes isotretinoin, the retin-A and the hydroquinone mix. These are all the creams the initial stages we give. But after sometimes even lasers will help. I refer them to a dermatologist. They'll take care of this the pigmentation with lasers. Sometimes it is permanent, it never goes. You have to make sure that tell the patient clearly, because if it is the exposed areas or the hip or something when they're wearing a sari, the pigmentation is going to be the major issue. If you ask me which is the only the complication other than the traumatic complication like a death or pulmonary embolism, is a major complication I worried about all the time. And same time, if you see a lot of the varicose veins, even if you see that lower picture, the down you can see a little varicose veins. Okay, if they have a varicosities, there is a more chances that you get the pigmentation. See, even the erythema, there is 2 kinds of erythema. The superficial erythema like this easily settles. If you see some darker, deeper, the redness, it's a little dark, black and red color. That is a little dangerous. Okay, initially it looks as if everything is okay. It's a little darker hematoma kind of, or ecchymosis kind of. But the day goes by, it try to comes to the superficial level. The skin depth is very common when there's a lipoma is deeper. I don't find a picture to show you, but I have a lot of patients like that. But we have to, if you see that one, you have to be follow all the extra precautions so that you don't get the skin necrosis. See, even sometimes the complications, what is this? See, sometimes we get to superficial skin peeling and full thickness skin necrosis. Usually those things are very common. Hypovolemia happens post-surgery, and the abnormally applied pressure because of the plasters or the garment. These are all the 2 main reasons you get and lot of superficial necrosis. Lot of superficial necrosis you're doing, and you're not taking care of the pressures in the by the plasters or the garment, you end up in a skin necrosis. Or sometimes because of the secondary infections to the liposuction areas. The only one complication, if it happens, extremely difficult to treat, is an infection. So make sure that your cosmetic surgery theater has to be like orthopedic theater. You have to follow all the extra precautions. You have to take all. You see, not even see like even we do reconstruction very relaxedly. Okay, now a little bit of compromise will be there, but cosmetic, you should not take any kind of a chance. See, even in this case, if you see superficial necrosis, but the superficial necrosis become a scar. She's a model. How will you manage? the initial days when you have this kind of a cases, your life will that you can't sleep, man. You have to keep thinking about it, what to do. See, nobody will guide you what to do. That's a major problem in the cosmetic practice. Wherever I go for the conference, I keep asking, sir, what to do for this, what to do for this. At the end of the day, we excise and treat it. The scar is also not looking good, contour is not good. So you should not get the complication. That's what I'm trying to do here, to understand why you're getting the complications. See, this case is because of the secondary infection. We did a massive liposuction. One is the hypovolemia. So the hypoperfusion of the skin. When you do a massive, almost we remove 14 liters from both the buttock and the thigh alone. Okay, so massive liposuction and hypoperfusion of the skin lead on to a secondary bacterial infection, so necrotizing fasciitis. Okay, we need to do no compromise. Since the patient is a cosmetic patient, you should not leave your general principles. Okay, it's a necrotizing fasciitis. It's an emergency. You have to do a extensive debridement. In private practice, what happens is, we have to answer the patient. Shall we postpone one more day? Shall we do antibiotics? See, our mind won't work that time. Okay, but never ever compromise in your general plastic surgery principles. So extensive debridement and serial grafting. This is how it is. End of the day, we made her happy. They understand one thing: complication can happen to anybody. Okay. If you see, three things you have to do when there is a complication. You have to always available to the patient. Never ignore the patient's calls. Make sure that you are visiting so often to the patient's room and make sure that they are comfortable and make them understand what is happening. And that patient will be your best patient. They will bring you more patients. Understand this. Complications you can easily manage. Unless, see, who is a good doctor? If you don't know how to manage your complication, definitely don't even do the surgeries. Okay, so only all the general plastic principles are important when you get the complications in cosmetics. So never ever try to have this in your practice. Infection, fat embolism, pulmonary embolism. When you're taking obese patients, unless otherwise you are in the institution setup, don't even try those things. The obese patients are about 120 kgs. Better to send them for a bariatric and never attempt. See, two reasons I might do even above 120 or 140, because for the skin tightening effect, if you do a liposuction first, then send them to bariatric, the skin tightening will be better. But none of the patients are willing to pay 2 surgeries in the subsequent 6 months period. So you won't get that kind of a combination. So try to avoid the people above 120 kgs and start with a small volume liposuction and slowly go to the next levels, multiple area liposuction or the other things. So I think I covered most of the things, the basics of liposuction. For each areas, we need to go for the separate, for example, tummy liposuction alone, where are the areas you need to concentrate. All those things will combine in the next level of lecture. Once we finish all the basics, we'll go to the next level of lectures. Am I okay? How long we took?
Sir, around total 1 hour.
1 hour, no?
Yes, sir.
Anybody wants to ask any questions? I'm ready to answer. TNS sir is ready to answer. Karan, if you have anybody's already asked any questions, any chat windows?
No, sir. No, sir. Till now, nobody has placed any questions, sir, in the chat.
See, if you guys interested to say, I saw a lot of messages about various topics like facelift, deep plane facelift, blepharoplasties, and other details. See, understand one thing. In a private practice in India, you get only majorly 2 cases. One is your hair transplant, other is the gynecomastia. This is a common area, common plastic surgery, common cosmetic surgery procedures you see. Next common is the liposuction. Okay. Then comes the other breast and tummy tuck is other volume. The facelift, see, I am doing cosmetic practice for 11 years. Okay, I have done 6 facelift till today. Okay, the 6 facelift is a major volume for any cosmetic surgeons across the Chennai. And same way, we do a lot of fat transfer. Yes, fat transfer also one of the common things. And don't try and jump learning a lot of non-surgical things because we haven't learned in a surgical practice. See, my advice is try to do minimal non-surgical work by yourselves, because then only your dermatology colleagues will send your patients. If you start doing dermatology work also, you don't get the reference from them. Understand that you are a surgeon. End of the day, never forget you are a surgeon. You are a plastic surgeon. And like most of the company guys try to dilute your ideas and make them like feel like, okay, I do a lot of fillers, botox. Yes, fillers and botox is interesting. As a surgeon also we can do it, but don't go and do all the chemical peelings and other things. Let dermatologists do all those things what uh, they can do. Any questions?
Sir, somebody has posted Dr. Vikas, Dr. Vijay. Any deaths in your experience, sir? Hello?
It's not clear. Your question is not clear.
Sir, Dr. Vijay has asked, do you have any experience of any deaths in your clinical practice, sir?
100%. We had one case, that is our mistake only. The thing is, he's a doctor, and he took some holidays, 1 month holiday from the work, and so he came directly here. He's obese. He's 130 kgs or something, and he's hypertensive, but he knows only after coming here, and the blood sugar shows very high levels of blood sugar, like the recently diagnosed. That's the first value he knows. When he come only, we diagnosed him as a diabetes. It's around 300 plus. We asked him to go back and come after a few months after that, nicely the blood sugar under control. He went to the diabetologist and got the fitness certificate. Even the next week, he said, "I'm ready for surgery." Still, we said, "No, don't. We are not willing to operate." But he said, "Diabetologist gave a fitness. What is your problem?" So usually it's not that way. The blood sugar has to be consistently controlled. Then only we have to do the surgery. So we did the surgery. Surgery went on very well. Not much problem. That day night, he developed diabetic ketoacidosis. Though he's on insulin pump and other things, it started developing diabetic ketoacidosis. And then the diabetic ketoacidosis followed by pulmonary embolism, fat embolism, everything joined together at this. Within 2-3 hours, we lost the patient. Actually, till next day morning, he's sir.
Yes, Karthik. I'd like to elaborate and tell one thing to everybody who are listening, young upcoming plastic surgeons or cosmetic surgeons. Don't ever think that, and then all the diabetologists, all the physicians, they don't have a clue what will happen in the postoperative period when you are doing a liposuction. For any other surgery, it is okay. But when you do liposuction, the problem is when the primary problem what we have when we are tackling an obese patient is insulin resistance. What happens in the postoperative period is your insulin resistance increases much beyond what you can think of, because the pathophysiology that is happening in the postoperative period, particularly in a liposuction patient, what happens is you inject adrenaline, and that to 10 liters, and then 10 mLs of adrenaline, and that is going to act. That adrenaline is a glycogenolytic agent. It is going to increase your blood sugar like anything in the postoperative period. And when there is a pre-existing insulin resistance that is already there, which is gauged by your HbA1c, your HbA1c, if it is even more than 7, you think twice to touch that patient. But what the patient we operated had a HbA1c of more than 12, and we outrightly rejected. But then he was so insistent, and then he went to his friend who is a diabetologist, who gave clearance with some treatment, but that is not going to just do anything at all in the postoperative period. And even otherwise, we have so many experience in treating diabetic patients who undergo liposuction, and from that time onwards, we are very careful. Even if the HbA1c levels are little above 7, we keep a close watch on the blood sugar, and then we actually give not only metformin, but also medicines like Galvus and some other medications which are new, which are going to increase the insulin sensitivity. That is much important. Only that will act. Plain insulin will never act. How much of our insulin that you're going to pump in, still your blood sugar will be relentlessly going up and ending up in complications like ketoacidosis. And this particular patient had a ketoacidosis with high dose insulin infusion, treated by a physician, but still he went on to develop a myocardial infarction on top of ketoacidosis and died. He had a cardiac arrest and died. We were not able to resuscitate him, and that was a lesson that has to be learned, and that will actually throw more light on that. Never ever touch any patient, even if the patient pushes you to your corner, pushes you so hard to surgery. You never agree to do a surgery on a patient with uncontrolled diabetes. And they think that, like any other patient, what liposuction can do, liposuction can produce havoc in the postoperative, particularly in a diabetic patient, obese patient, where resistance to your insulin will be very high. Even if you give pumps and loads of insulin, it won't help. It will not reach the patient. It is not going to turn around the medical complication, and patient can end up in a ketoacidosis, which can cause further complications, and the patient can go on to die. And coming to one other complication, this fat embolism. We have seen quite a few on the table. Fat embolism, we will be able to pick it up very easily. Sudden fall in saturation with bradycardia, with instantaneous shoot up in BP, which will follow by severe hypotension. That is what usually happens. Best is immediately you cut off everything, ventilate with 100% oxygen, and then give supportive care. If the BP is low, then you increase the BP with the push of ephedrine, and then go to adrenaline infusion or noradrenaline infusion, and maintain oxygenation. Even if you have a SATs of around 90 or 85, don't worry, slowly it is going to improve. And 90% of the time, mostly that resolves, because it is good that it is a fat embolism. Your fat actually will get dissolved, it gets autolyzed, because it is an adipose tissue. Lipolysis happens and the size of the embolus goes down, and then your hemodynamics is going to improve within no time. At the most maximum, we have ventilated, or even with a CPAP, we got to get away, and then with oxygen therapy for 24 hours for one patient, if I can remember, and 2-3 patients needed only 2-3 hours of oxygen therapy, and further the blood gases improved dramatically. And at the end of the surgery, patient will be comfortable. They won't even know actually that they had such a fat emboli and leading on to complication. They just come out just like a normal patient. So if you do 2 to 3 hour surgery, early in the surgery, if you get and fat embolism is very common when you do liposuction in abnormal places, like say forearm, where you use thinner cannulas. And what happens is, when there can be a small fat embolus that can happen, actually that's when we come across fat emboli very frequently. I am seeing something on the board. Somebody has
Yes, sir.
put up a question. Do you need to know about the respiratory functions preoperative, especially in smokers? Yes, that's a very good question. Pulmonologist, okay. So pulmonologist opinion, if you get or not, that is not important. See, younger patients, even if he is a smoker, he or she is a smoker, because there are many she smokers that we see. We have to be specifically asking for smoking history in the evaluation. And pulmonologist opinion is only for documentation. If you need it, you can get it. That doesn't matter. But then you have to assess the pulmonary reserve. See, smoking does not mean that your respiratory reserve is poor. The reserve may be adequate. He might be an athlete, but still he smokes. But the thing is, the after effects of smoking, like say smoking causes so many effects all over, right in from the vascular plane to the cardiovascular system and in the respiratory system. What happens? Smoking causes ciliary dysmotility. And then immediately after the surgery, there are a lot of complications because atelectasis is more common. And if you are increasing, if your duration of surgery is more than that can produce. So see, when a patient is coming to gynecomastia, you're doing for a smoker, I'm not worried about his pulmonary function. He is going to just jump up, and then most of our patients are up and then walking and then getting discharged at the end of 3-4 hours. That's it. So there we are not going to see any respiratory complications. But if the surgery is going to be prolonged, and then like a prone position, and then if it is a multiple area surgery where you need to cut open skin and restate, whatever it is. So if the surgery is going to be prolonged, then there you can see respiratory complications in the postoperative, increased chances for infection, atelectasis, and if they have other comorbidities that can add on to, can lead on to ischemic problems, ischemic heart disease can worsen, they can come up with new ischemic changes in their ECG, all those things are there. And then even a acute myocardial infarction is very probable if he is in that age group. So smoking has will not actually directly extrapolate to reduction in the respiratory function, but you got to evaluate along with all other comorbids. So if you can ask the patient to stay away from smoking for 2 weeks at least, most of the cases are elective surgeries, and if 2 weeks of abstinence can really help bring up the respiratory function back to near normalcy. That is 90% of respiratory function can be brought back. So what, and the vasoconstrictive effects of nicotine is that you got to be worried about if you are doing a smaller surgery like gynecomastia, where skin necrosis, all those things are a problem rather than a respiratory function. Respiratory function, yes, respiratory function normally, even in a normal patient for prolonged surgeries, there will be a reduction in the respiratory function, right from your residual volume or total lung capacity, everything, along with your ciliary dysmotility, everything can add on and increase chances for pulmonary embolism too. That also, that I'm talking about thromboembolism, leave alone your fat embolism, thromboembolism, everything, the rate is very high. You're operating on an obese patient and for a long period of time, and you got to be very clear about DVT prophylaxis. Always there will be a conflict of interest when it comes to, okay, you got to have, you will be ending up producing more heme loss because of a prolonged liposuction. We always have, I'll always go for DVT prophylaxis apart from mechanical compression with TED stockings or even a sequential compression device. But Karthik will be very hesitant to put the patient on a low molecular heparin because he'll feel, he will try to avoid blood transfusion. I'll always tell life is more important, Karthik, and then it is better to err on putting them on a low molecular heparin and giving a blood transfusion, even no harm. But then pulmonary embolism is going to kill the patient instantly. And whether you give the blood or not doesn't matter. So life is so important. So it is always give. So that's why you 2-week abstinence will reduce the incidence of pulmonary embolism very greatly. We have all the evidence-based medicine helping, and 2 weeks abstinence going to clear so many trouble. And regarding the respiratory reserve, Vijay Como, respiratory reserve, yes, it matters, particularly everything you have to categorize whether the patient surgery is going to be prolonged or if it is a simple smaller surgery. Respiratory reserve will be taking a beating, but we won't mind if it is a smaller surgery, but you've got to be more worried about other things.
Okay.
So actually, there is few other questions. See, the other thing, why I'm hesitant to go for the low molecular heparin is we have few instances where, like patient, very stable patient, and as soon as the low molecular heparin, there is a huge blood loss, and we need to, the middle of the night, we need to run for the blood. And like,
yeah, I understand. And again, I need to tell you one thing, Karthik. What happens is, like, as far as the vasoconstrictive effects are there in place because of your tumescent, and later on, once when the vasoconstrictive effects are gone, adrenaline effect is gone, there will be more oozing, and your low molecular heparin can compound it. That's why if there is more blood loss, we have more troubles from all frontiers. So here you have to give protection for embolus, and here you got to make conservative efforts to reduce bleeding. Both are very conflictive, and you have to strike a balance. Otherwise, either way, it is going to be troublesome. But there, you got to be having a very clear idea of your blood loss, and then if you feel that that's why H&H is very, very important. H&H, I mean hemoglobin, that is hematocrit and hemoglobin. Not only hemoglobin, hematocrit also is very, very important. Do a H&H immediately 2 hours after surgery if your surgical aspirate is crossing 8 liters, and then do it the very next day again. So again, whether you give low molecular heparin and whether low molecular heparin has compounded your blood loss or whatever it is, and your heme loss will be taken care of. And if there is a need for transfusion, go ahead with the transfusion. Or if you don't want to give the transfusion, stage by stage, do a liposuction under safe limits. Restrict your lipoaspirate to less than 8 liters. But then at a point of time, you need to definitely cross that. And then people will not be satisfied if you're just taking little by little, and then they won't come again and again to subject them to surgery. You have to be very, very clear in discussing with the patient about the need for transfusions, about the need for staging, and decide appropriately. I think you need, as experience grows, then you will know how to tackle each patient differently.
Very nice.
One more patient. How much liposuction you can do in a single sitting? See, as he said, see, if you explain to the patient properly why you should not go for the massive liposuction in the single stage, why you need to go for the multiple stages liposuction is safer for you. If you explain it properly, most of the patients will agree with you. But a lot of times, the time factor, they come from other places. They want to finish everything in a go and finish the liposuction everything in a go. If you have a good setup, good team, see, even I removed up to 14-15 liters in a single sitting. Okay, but I don't support it. Okay, but other problem, what happens is sometimes we can't even guess. You plan few areas, you normally you think that okay, this only 7 liters will come. But when you keep doing it, when you see that aspirate, it will be around 12 liters, 13 liters. You know, like till today, it's very difficult to guess how much is the aspirate going to be. See, you finished one side, other side going to go, you can't leave and come. These kind of situations, most of the time you stuck. You can't stick with the volume like only I plan 7 liters, it's going more than that because we finish only one side. Other side, we need to do it. So these kind of a situations we need to do. Usually the females, the size of the fat cells will be more, the volume will be more than what you assume, how much you're going to remove. The males, you think I'm going to remove a lot, but it will only come. So some reason the aspirate will be lesser in males than what you assume. In females, it is more than what you assume. Just for your practice, this is practically what I have seen. Another question, the skin necrosis.
Yes, the skin necrosis, and how do you manage and counsel the patient?
Yeah. First of all, the skin necrosis, what I've shown you in my first year of my practice. Okay, think about me. She's a model. Okay, convinced that most of the problems happens, like the smokers and the passive smokers. Not only the smokers, the passive smokers are also equally important. And as I said, second thing is prevention is much, much better than getting the full thickness necrosis for sure. So prevention, what are the things you should not do? Very superficial necrosis, the liposuction in a continuous manner. Say example, see, sometimes I do a midline rip means I only create the midline very superficially. I don't go all around to the liposuction the same way. Okay, so discontinuous superficial liposuctions are okay. Still, that area alone might struggle for the blood supply, and then it heals off. Second thing is the government has to be properly, as I said earlier, there should not be much pressure from the government as well as because of the plasters. These two things you follow. Post surgery, the adequate moisturizing cream applications and all those things are also important because when the skin is very shriveled and it easily goes for the folding and necrosis and all. Uh, other problem is most of this necrosis won't be immediate. It will be very delayed. Usually we see after 2 weeks, sometimes after 4-5 weeks and all, the skin necrosis become more, like visible. So that's why I usually tell, I told you earlier, the dark black pigmented patch, always you need to be little aware of. It might go for a late necrosis, because usually a mild hematoma like this tends to come out, it will be in between skin layers. It tends to come out and tends to injure the skin. So how will you manage it? It's nightmare only. As I said earlier, any complications, how you manage, sit with the patient, be with the patient, always available for the patient. And yes, obviously, they'll send you patients. Okay, so it's when you neglect the patient after the complication, only all the issues will happen. If you are sit with the patient, make sure that tell them that it happened. Definitely, it's not very common, but I'm going to sit with you and manage the problem. Make sure that you are going to be happy. Yeah, obviously, you can't sleep when the other patient is unhappy because of you. You got the point? So the cosmetic practice is completely different. That's what I'm telling the people also, because about a lot of list of things you ask for the facelift, neck lift, and all you never see in your practice for the past 7-8 years. But definitely, I'll teach you all those things. But what I'm trying to say is, how to consult in the cosmetic surgery is a major thing. Like nobody will teach you. We'll take few classes for the consultation skills in the cosmetic surgery practice in some of the classes. I hope I answered most of the questions. Anything else?
Yes, sir. There are no questions as of now.
Guys, just comment about the class, how it is, and whether any changes you want to do, because I'm very new to this teaching, okay? Because I don't have any postgraduates to teach, so we are all very new to this teaching thing. So any comment, feel free to discuss in the group. I'll be reading all the messages.
Sir,
So,
sir, sorry to interrupt you. You were going to show one video, sir. You told you will show it at the end.
yeah, sorry. Yeah, I have to share my screen now first.
Yes, sir.
Okay, where is the share? Okay, here it is. Okay, just basically how our center, how we do see a lot of, this is a marketing video, don't go much into the details. You see the marking, how much marking we have done here. So this arrow and all tell me where is the curve going to be. This is infiltration. We normally make a 2 cuts in this area, the liposuction. So first we'll go with the deeper, and then we'll come to the superficial areas. So the lipoaspirate has to be like this. It shouldn't be very much blood stain. You can see the curves, how we are creating it. This is infiltration again. This is actually a tunneling. We do something called tunneling subdermally for the skin tightening purpose. We do the subdermal tunneling. This is how we apply the plaster post surgery. Can you see the midline drift? How I'm creating? I'm doing a superficial liposuction here. It's the way how we create the midline drift. And same way, I finished doing a liposuction for the one side of the tummy. You can see this one complete area is sculpted like anything. I only kept the midline fat alone. The same patient whom I shown you in the initial thing. Extremely happy client, and completely changed their limb chances are completely increased after this liposuction. Very grateful patient to me. The 2-month post-op. This is the same chamber, a lot of girly things. So you guys are always welcome to visit our center and watch our videos once the lockdown is over, and we'll be willing to teach and willing to help you guys. But we take only 2 post MCH PGs in 6 months period for a small paid fellowship program. If you guys are interested, now Karan is with us, and definitely we'll be helping you. But the only sad part is Karan, as soon as he comes, the lockdown started.
Yes, sir. Bad luck for me, sir.
So, thanks to Sheetal, Dr. Tanuja, who are all with us earlier. And Tanuja is practicing in Hyderabad, Sheetal is practicing in Madurai. And hope this section is going to be helpful. And thank you, Dr. TNS, sir, for a wonderful session.
Thank you, Karthik. It was so very wonderful interacting. Thank you.
Thank you, sir. Thank you, sir.
Thank you.
Bye, sir.
So
Thank you.
now I'll try my best to prepare for the Tuesday. I don't know, it's a little difficult only for me to do 2 classes per week. I'll try my best to come on Tuesday. Otherwise, we'll have a classes every Saturday.
Yes, sir.
Next topic we'll post you tomorrow morning.
Okay, sir.
You coordinate for the next topic. Thank
Yes,
you.
sir. Okay, sir. Bye. Thank you, sir.
Okay, sir. Thank you, sir.
Okay, sir.